We'll go on to the next speaker, Dr. K.S. SIDDHARTHAN, again a young dynamic DMEK surgeon, who will show us the DMEK dance, ensuring the graft is the right way up.
Thank you, Rishi, for including me in the part of your team to teach DMEK, which we have been doing for the last 2 years. I think 2020 we did, and after that again we are doing it only now. So the DMEK dance, ensuring the graft way, I think Ashish very beautifully explained the way how the DM is being prepared, and Rishi gave a very brief lookout on all these things. So here I am going to show you completely only videos of how to unfold the DM, how we used to do before and how we are doing now. So this is a very favorite slide of mine. Like the DMEK is pretty difficult because the DM always scrolls on itself, exposing the endothelium out. So this is the biggest problem, because if you take it in a glass or you take it in a fiber, whatever, the DM is out and it's out to get damaged. So here you can see here, you like a DSEC, if you want to put a taco fold, I am putting a taco fold and putting into the saline. The endothelium is actually inside, but the nature of the DM is such that you see it flaps open and the endothelial side comes out. So this is the biggest problem we face, because in DSEC the endothelium is inside safe, whereas in DMEK it's outside. That's why there is so much of loss. So the marking, as Ashish told, you can mark anyway, but I do a L, very simple. This thing is, there's a horizontal short limb and a vertical long limb. So you have to make sure that the short limb is always on the right side, meaning that you are sitting superiorly, nasally, temporally. Make sure, imagine you are sitting on the side of the L, and make sure that the horizontal part is always on the right side. Like you can have an F, you can have an S, that depends on your comfort, but for the beginners I think this single one should be a very easy one. So from starting with the DM scroll injection, it's very important that the size of the tunnel is very important, because here, as you see here, I am trying to inject air, I inject saline, I am trying to inject the tissue, it is not going in. It's not that I am using the same amount of section, everything, but you can see I am injecting saline, thinking that the iris is coming and plugging in or something is happening. But a very simple thing is, when you feel, just slightly extend it from 3.2 to or slightly more size, and try to reduce your positive pressure when you inject. Okay, just reducing the speculum, adjusting the speculum and the size can easily allow you DM to enter in. So first, DM sizing of your tunnel size is very important. The second is your scroll size. So these are very important, because here I am making a mistake, because this is a 6 mm, almost 5.5 to 6 mm opening, and I am using a graft of 7 mm. So you see that it always goes and impinges around the pupil, and it will not open. And in an experienced hand it will open, but when you start it's going to be difficult. Here a case where you are having almost a 6.5 mm pupil, I am using a larger graft. So here, when you have a larger pupil, try to use a larger graft. You can see here that both the edges of the graft are sitting on the iris as a fulcrum, and it opens. So please size your graft according to your pupil size, and that is very, very important for your DM unscrolling. And again, early cases, don't take very young tissues of the 40, 35, 40 and all. Please don't take. And this is a video which I am showing you, like not to take a young scroll. And actually this is actually an iris claw done, vitrectomized eye, a very soft eye. So all these things don't try in your initial days. After you do your practice, start with around 50-60 years of tissue, clear cases where you have a good pseudophakic, the in the bag IOL and all these things. Otherwise it's going to be really tough to really practice this. So you can, when you take a elderly tissue, you can see that it very beautifully unfolds inside. So you don't need to manipulate, and your confidence levels more. So you see here, as even before putting a suture, I am giving a few taps and it opens up. So use elderly tissue. Make in mind that you use above 55 to 60-65 when you start, so that you are comfortable to unfold. So here are few of the techniques, as Vikas was showing you. I'll be showing here. So initially we used to tap. Initially when we used to we used to tap. But before you do any of these procedures, put a suture. So if it's going to be a 3.2, whatever size, apply a suture before you manipulate the tissue, because the tissue is so small, so thin, it will come out very easily. You can even put a slightly tight suture because the AC can shallow. So here, before, what we used to do is we used to inject saline, and then we used to tap the tissue like this. So this was what we were doing about 4-5 years back, complete tapping. So this was very destructive, because when you used to tap, just like grapes, how it used to be sticking the DM, the cells will just fall and you'll get a lot of damage. So this was what we were doing initially. And the mark, as I showed you, is which was guiding us. And as Vikas was telling, initially everybody starts. I started in 2013, stopped, again restarted in 2015 after I saw the marking. So once the mark is there, it makes your life very simple. So this was the initial tapping one. And the second phase was when we used to have two hydro needles. You can actually inject little bit saline, and you can do like this. You're seeing how Vikas was showing. It was just the same way. You keep tapping with both hands and you try to unfold. So this was the second type. We didn't want to tap too much. We just wanted to do a little bit of very gentle tapping and unscrolling. But it's not always that this type of unscrolling always happens. And you can see here, I just a little bit speed up for the time. So what happens is, sometimes when you try to unfold like this, and you try to do that, it might not always unfold. So it was not that easy to unfold. So we used to face these type of problems. So what generally nowadays what we do is, we use the hold and release technique. So where with the left hand I hold, and with the opening I inject saline, I shallow. I inject saline, I shallow. See, that's the technique. Now it's very, very smooth and it unfolds very, very well. So only thing is, you have to make the tissue lie horizontal always. Don't make it vertical. Always, if you're sitting temporal, always make it horizontal, so that it's very simple, it stands in. So this is, again, I'll just show you a very easy one. So you hold with the left hand, inject saline, hold it, push it to the whichever position you want, hold with the left hand, inject saline, and it opens. So this is a technique which we use. And here I want to show you suppose the orientation is wrong, it goes in the opposite side. This is an old IOL, anti-chamber IOL. I'm removing it. I done an iris claw, and then after that I am putting a suture, 3 sutures, and then here what I want to show is, like, I'm trying to unfold here, and it unfolds. But you can keep seeing, I don't know whether you can see, it's unfolded the wrong way. It's unfolded the wrong way. I'm doing the same technique, and you can see that the L mark is on the opposite. So here what I do, how do you reverse it? Hold with your left hand. I'm injecting the saline under. You see the tissue, the fluid is going under. With the left hand, I'm making sure that the fold is staying, and with the right hand, I'm injecting saline, and keep looking at the inner flap. You see how the flap came out? So that's how you have to reverse it. I'll show you one more video also. So once it reverse, hold with your left hand and you unfold it. So that's how you have to give the saline under, and that's how it moves in. And I'll show you one more where, again, here I'm trying to unfold. So once I unfold, I will find it that it's not in the right side. So you see that I'm injecting saline over the inner flap. You see, I'm keeping on injecting the inner flap, and see how the inner flap comes out, flap out. So that's very, very important. You have to give the flow on the lower inner flap so that it comes out. So again, a few videos, because of no time, I'm just going to forward it. And the only thing which I want to keep telling you is, always make it horizontal, hold it with your left hand, keep injecting saline, shallow it. Injecting saline is the key. So that makes it really easy for it to unfold. So these are the few techniques. And one more thing is, in regrafts, what I've learned is, always try to take a graft size lesser than your graft host junction. Don't go for a bigger one. Here, in initial cases, I took bigger one. It's very difficult to unfold. Also, in the graft host junction is irregular, so it will not stick properly, and post-operatively you will have problems. And here, in initial cases, I took a larger graft as usual, how you take in regular cases, but found it really difficult. So this is another case I'll show you. You take it, the graft size, take it lesser than your graft host junction. Maybe if it's 7.5, take 7.25 so that it easily unfolds and the barrier actually does not allow the DM to go out. Yeah, thank you.
Thank you, Siddharthan. Those are really good videos, and I think you gave some nice surgical tips. I'm going to try that inject and release.